Hello. What a pleasure to talk to you, my friends, again. My name is Dr. Jose Luis Ruiz, and I'm the director of Los Angeles Institute of Clinical Dentistry. And today we're going to talk about, a very special subject. We're going to talk about the intersection of aesthetics, combining ease and biocompatibility on direct restorations, and specifically looking at a material that can actually help us achieve all of these things, which sounds quite a big promise, right? During my presentation, I will talk to you a little bit about the principles and why would this matter. And of course, I do want to share with you some step-by-step techniques. An hour is a small amount of time, but we'll try to do as much as we can. But how is that a material, a new material, really can give us all of those benefits? So we're going to talk about that. We're talking about a material called Admira Fusion Extra, and this is a material from Voco, and it is unique. And it has a combination of things, which is very unusual for dental materials to be able to offer so many benefits all at the same time. It has 4 big benefits, which are different than most other materials. It has the ability to be omnichromatic, which means it actually absorbs or has a chameleon effect. It has deeper cure, and of course manufacturers suggest 4 millimeters. I'm not quite there, but you can definitely cure deeper, and that's very important. But it's even more than that. The low shrinkage is quite important as well. We will talk about this, by the way. And then of course something that I find very exciting, that's why I put it in blue, is BPA free, and that means it's more biocompatible. We will talk about that. I'm, as I mentioned, Jose Luis Ruiz, and right there you see a little bit about myself. And of course, I have good working relationships with most manufacturers in dentistry. I lecture and talked about materials. I talked about all kinds of materials from all kinds of companies. This time I want to disclose that Voco is sponsoring this lecture, this webinar, and I like Voco because, unlike some of the companies, they don't tell me what to say. They know I like their material, and so they invite me to talk about it, or to talk about dentistry in general. And I'm not just going to talk about one thing. I've never have, and I will never allow that. I appreciate companies like Voco that promote education without being intrusive, and that's special. I could tell you a lot of other companies, they are very different. And of course I don't do something like this for them. Why would biocompatibility matter to us in dentistry? Actually, biocompatibility, holistic dentistry, is almost a cuss word in dentistry. It's been so maligned because some people have taken it to the extreme, and but really biocompatible is actually quite an important thing, quite a wonderful thing, and we should all strive to do dentistry this compatible with life and health, right? I mean, why would we not? I mean, people want to live a long time. People spend a ton of money buying organic lettuce and organic everything, and working out and staying healthy and not putting unhealthy chemicals in their body. And we pay a lot more money than we would if we bought the cheap stuff. And because people want that, and of course we should want that because we want to stay healthy. The thing is, dentistry's kind of been running behind on this. We still have the idea that you have a broken tooth and then you're stuck with whatever you're stuck with, and we see a lot of patients that come into our practices with badly damaged teeth like this one, And the solution to that is something awful like this: crowns with subgingival margins that cause inflammation. And, you know, of course, we know the research tells us, and, you know, this inflammation that we see around the gums is not going to stay in the gums. You know, actually the literature, and we know this literature, the medical literature, the dental literature, the more we learn about this periodontal inflammation caused by these crowns and by other restorations and by materials that might not be too compatible with the body, but specifically it's worse when we put the stuff below the gums. You know, the medical literature tells us that chronic inflammation and oxidative stress is the major contributor to aging and disease. Wow. What do we see on the internet? You go to WebMD, and when you read about this inflammation, chronic inflammation and infection around the gums, which can be easily caused by our restorations, not just crowns, with fillings and anything that we do that we put below the gum. Again, it causes inflammation, and you see all kinds of, you know, terrible things, including, you know, I mean, the more we read, the more you read the ADA news, the more we learn and realize how damaging this is for our patients. So in dentistry, for way too long, we just been with this idea that you know, the patients come in and they say, you know, I want something healthy, and we just basically, you know, say, well, you get what you get because this is what we have, and this is the material that I have, and this is the technique that I have, and your tooth is broken, and this is what you get, you know. And of course, because of that, I think a lot of our patients end up going to places where they might offer something different that might not be as you know, evidence-based. But do we still live in the time when we don't have choices? And the answer is absolutely not. We live in times when adhesive dentistry materials are better, and we can avoid things like this by doing healthy supragingival dentistry, adhesive dentistry. It really changes the rules. And by the way, may I just, you know, a little commercial, you know, this, doing veneers properly with supragingival margins, learning how to use adhesive dentistry is such an important thing. We, you know, in Los Angeles, if you ever visit Los Angeles, you can you know, stop at our workshop center, the LA Institute, Los Angeles Institute of Clinical Dentistry. But really, you know, with fillings is no different, by the way. You know, how do we learn in dental school to break contacts, cervical contacts? You have you know, a cavity, you prep your class 2, you remove all the caries, but you're still in contact with the adjacent tooth. You know, in dental school, and I know because I taught in dental school, you know, you learn that you have to break contact. When you break, how do you break contact? By dropping the margin, by cutting that cervical floor more apically until it separates. Often putting the margins below the gum and going back to all that chronic inflammation and healthy margins and stuff like that. So we can alter our techniques and give our patients better dentistry. You see, this subgingival margin thing, this breaking contact, this slavery to dropping the cervical floor causes things like this, where you see a patient with no caries, and then they end up with a crown with deep subgingival margins, and this poor kid, a 19-year-old, has a puffy gums forever. Stuff like this taught throughout everywhere you go. This is at the, you know, I was surprised at the Spear Center learning this onlay techniques using CAD cams, and the person teaching there was suggesting that we should be dropping the margins aggressively to create a lot of separation. And you see this picture right here with the gums completely abused, the deep subgingival margins, and this is very, very unhealthy. You know, the literature shows so. So let's break free of this techniques, this idea that we have to put things below the gum for whatever reason, whatever excuse that we may have, and you know, alter these techniques to something more modern, more healthier, but more minimally invasive. We can either put when we do our class 2s or class 3s, we can pre-wedge and create separation. Or if we need to, we can always use a mosquito bird and create separation. We can use a fender wedge and do the separation with protecting the adjacent tooth with a fender wedge, which you see right here. This is going to make the restorations healthier because we're going to keep the margins above the gum. It makes all the difference in the world, you know. And why not? Why not avoid those things? But look at this. This is another issue, you know. Biocompatibility of dental materials. Let's be, you know, how many times have you seen patients with this tremendously inflamed gums, and it turns out that the reason was they were allergic to certain metals. You know, there's a lot of patients that are allergic to certain metals, certain acrylics. I've treated patients that they were tremendously, you know, allergic to acrylics, and they actually would get sick, and we had to even do a biocompatibility test. But altogether, why not use materials that are that are more biocompatible, right? I mean, you know, it doesn't hurt, especially when the materials are amazing, right? And fortunately, we live in those days. Today, we have materials that they have that benefit of being biocompatible. For an example, is Admire Fusion Extra. It's a material that is BPA free. In other words, it uses a technology, it's a new technology. I mean, it's not so new for this German company Voco. They've been using Ormocert for a while, but the benefit of it is it does not have the traditional bis GMA chemistry, which releases some undesirable chemicals. Now, is that a you know, is that a humongous problem for everyone? No, let's not exaggerate. Let's understand that most patients can handle, you know, but there's some exceptional patients. And of course, patients, they want the healthiest possible options, the most biocompatible options, and those patients will benefit from this. I tell you, my practice, when I have a lot, I practice in Studio City and in Burbank here in Los Angeles, and patients are very concerned about this, you know. So when I tell them that I use a material that is BPA free, they're super happy about it. They're excited about it. So we you know, we have at Los Angeles Institute, you know, we have a you know, organization called the Academy of Supragingival Healthy Dentistry, in which we talk about, and all of our courses and all our lectures are about supragingival healthy dentistry and giving our patients restorations that are healthier for them, that has less side effects. And again, why not? Why not do that if, in fact, by using these techniques and these materials, we can do dentistry that is faster, easier, more predictable, that is healthier, you know. And something that is very important, my friends, is that it allows us to differentiate ourselves in an ethical way. We can provide supragingival margins, which are healthier for our patients. We can use materials that are more biocompatible. People like that. You know, I tell you, my practice benefits tremendously by educating patients about the benefits of supragingival margins, benefits of minimally invasive dentistry, the benefits of adhesive dentistry, and certainly the benefits of more biocompatible dentistry. So it's a win-win-win. I don't have to be the cheapest dentist in the neighborhood. People come to me because they want healthy dentistry. You know, by the way, some of the information that you see that I'm sharing today is information that is available in my book, Supragingival Minimally Invasive Dentistry, a healthier approach to aesthetic restorations, which are everything that we do, with the amazing contribution of Dr. Ray Bertolotti, who is, you know, as we all know, one of the leaders, the founders of adhesive dentistry in our country, the U.S., and certainly contributions from amazing people, you know, some of the best researchers in dentistry. So this is available, you know, but it was published by Wiley Blackwell. So There's a lot of good information. And may I just say a little bit about myself for just 2 seconds, if you allow me to just, I've been talking about this super gingival healthy dentistry for a long time. That's 10 years ago. That's 10 years ago, me with a big hair, which is a little silly. Sorry about that. But yeah, I'm a practicing clinician. This is what I do all the time. And I'm originally from Mexico City. I don't know how many of you have ever visited Mexico City, but you might want to consider visiting Mexico City because it is quite a beautiful place. It was historically, if in case you don't know, it was the capital of the biggest viceroyalty in Spain. It was the capital. It was the capital of a huge, all the way to Philippines, Cuba, Puerto Rico, all the Caribbean and Central America. So the city is spectacular. It was built like, full of castles and gorgeous places. And you would be impressed if you ever happen to visit. I encourage you to do that. And of course, even before the Spanish were there was beautiful, the biggest concentration of civilization in the continent was in that area. All these great civilizations that established beautiful places. So that's where I'm from. I've had the amazing fortune to learn from great people, like my good friend Gordon Christensen, my good friend Dr. Ray Bertolotti, and so many other people. And I taught at USC and CR. So what I share with you is, so of course, sitting in the shoulder of giants, great people, they share great information, and a lot of that stuff is in my book, and I'm representing the Los Angeles Institute of Clinical Dentistry, which, we have a beautiful facility in Studio City where we have all the latest in education and, small classrooms for to teach all these techniques, all this, adhesive dentistry that changes the game. So yes, biocompatibility is very important. I consider, it's very important to me. I want to have dentistry whenever I get any work. I don't want anything below the gums. I want to try to have materials that are healthy for me. And, I think we, if we know there's an option, that's what we want. But interestingly enough, this biocompatible material also has a very unique characteristic. It's omnichromatic. In other words, it's a material that would match the color. It has a chameleon effect. It matches the color of the surrounding structures. So you only need one color to restore any class 2, any class 3 is indicated for class 2s, class 3s, class 5s, not class 4s. You need tooth structure to be able to match. So why would that be a benefit? Well, let's think about it. First of all, it saves time because you don't have to be looking. You don't have to be checking for shade, right? You just, it's going to match it. And I tell you, I've been using it for a while. It does. It's kind of interesting. I know there's other companies that have similar materials, and and certainly they work amazingly. What's another advantage? Inventory. You don't have to have a big box of all kinds of different shades, right? You only have one shade for most of your restorations, and that that's actually savings. It saves you time. It saves you money because you don't have to have all those materials that eventually expire and you waste money. So in fact, you save money by having a smaller inventory. And of course, in my case, it saves my neurons because I don't have to be thinking about it. I love that. It makes my life a lot easier. Sometimes, like just recently, I had a patient that came in with a broken veneer, and I had to just repair it temporarily while we had sufficient time to replace some restorations. And by the way, this was not my veneer because I don't see veneers break very often when they're done correctly. But nevertheless, I just did my bonding procedure and didn't even have to choose the shade. I just used, this omnichromatic material, and done, you know, as you see right there. So it's pretty cool. But you know, you can see this omnichromatic capacity, but the other things, I mean, that's what makes it unique, that it has other more advantages, and one of them is low shrinkage. And so how do you see clinically, and this is something that I've seen personally, uh, um, how do you recognize clinically that there was low shrinkage? Well, you don't see a white line, you know, on the restorations. Isn't that interesting? Because, you know, white lines are caused by polymerization shrinkage, and then you see the little crackling of the cable margin, that enamel on the cable margin, that chips during the polymerization shrinkage. Of course, technique also matters, and I'll tell you about that. Um, but having a material that has low shrinkage is very important. Now we need to pay attention also to stress, you know. Admire Fusion Extra has a pretty low polymerization shrinkage. It's 1.25, which is very low. It's definitely one of the lowest in the market for sure, by far. The average, you know, what 2.5%, 3%. So then believe me, it makes a big difference. It makes a big difference. And of course, it has a great depth of cure, which allows you to put larger or deeper increments, you know. I'm going to share with you the technique. So my goal is to share with you a technique that I know is going to work, you know, so I will be sharing that with you. And I'm not a big person on just putting a big bulk in that set. So I'll share that with you. And, you know, if I can tell you that I've done this, you know, many thousand times. If you follow this technique, you're going to be problem free, and it's going to be super easy. So a couple of years ago, I published a little clinical article on Dentistry Today, and you know, it was about the 15-minute class 2, and of course you can expand that to class 3. And why would it matter to be able to do it quickly, but still super gingival, is still minimally invasive and definitely healthy? You know, all of that in a very small amount of time. Does that interest you? Should that interest you? Of course it does, because when we can do that and we can give our patients beautiful restoration, fast, quickly, beautifully, and healthy, man, we're really doing well for our practices. We're doing well for our patients. That's the way it should be. Because you know, insurance companies are not going to pay us more, you know, if we spend more time. So let's talk about that a little bit. So first of all, we have to break free from GB Black. We have to break free, you know, and I can tell you that the people in Dental Town, which hate me, they every time I talk about resistance and retention form is history, they get super upset. I mean, there's so many myths out there in dentistry, but certainly we need to get rid of a lot of the stuff that we learn in dental school, because it holds us back from being able to provide our patients, you know, this type of healthier, adhesive, minimally invasive dentistry. So let's you know, the preparation is very different. No more GB Black, boxy, no boxes. You know, just remove the caries. You know, it's we need to use more minimally invasive caries removing techniques. There's a number of that. And of course, we have limited time, so, you know, but we're going to talk about that. You know, preserving enamel, trying to keep supragingival enamel, you know, that's very, very important. No mechanical retention, no really minimal bevelly. Let's talk about that right now. So no specific outline, no boxes, you know, no dovetails. You know, really the smallest possible preparation that we can do. Good magnification is important. Breaking contact is really a thing of the past. I routinely use a fender wedge to create to pre-wedge, and also to allow me to work without having to worry so much about the adjacent tooth, which makes me a lot faster. When you do that, when you pre-wedge, usually you don't have to break contact in order to pass your matrix band. But if for whatever reason you have to break contact, I only try once. I put my fender wedge, do my preparation, which is super fast, and then I put my matrix. If my matrix doesn't go the first time, I go back with my mosquito burr and break contacts with the mosquito burr. And of course, using the fender wedge to protect the adjacent tooth. A lot faster, a lot faster. So on that article that I mentioned to you, I talked about a 2x2x2 preparation, basically two millimeters wide, 2 millimeters deep into the tooth, and 2 millimeters apical. Maybe a little bit more apical. It could be 3 millimeters apical. The important thing is stay above the gum. So when you do that, when you create that very, very fast a tunnel preparation, then you're not breaking contact. You're not gonna flare your preparation to break facial and lingual contact, and certainly often not cervical contact either. You're gonna end up with a situation in which you're gonna, you have a kind of a clean periphery, but internally you're still gonna have caries. And these are special teeth that I've developed to teach at our workshop center. So you see that little black thing that you see right there, that's actually fake caries on the tooth. And then after create that quick preparation, then we use caries detector. There's a lot of great research on this, going way back, all the way to the father of adhesive dentistry, Fusayama, who even back then educated us that the caries detectors are much more minimally invasive in the remove, while we remove caries. And more recently, Pascal Magne and David Alleman reminded us of the importance of using caries detectors to minimize the amount of tooth that we cut away. This is where minimally invasive dentistry is going to, so you apply your caries detector. I like this one. This is from Carrare. You put it on the tooth, then whatever is red you remove, and whatever is very super light pink or not stained, that's left behind. So allows it to very, very quickly remove the caries and really easily identify it. And that's a wonderful thing. So once I create my initial outline, which is a small external outline, then internally I undermine the tooth. I just remove whatever is inside of that periphery, that clean periphery, and then end up with a preparation that is internally considerably more expanded. So it's going to leave me with some enamel that is going to be unsupported, right? You can see some unsupported enamel here, just like we have done for years and years in the facial as well when we do class 3s. So what do we do with that unsupported enamel? And that's a very important question. That's a technique. That's a technique that I use in my practice every single day, endless amount of times. This technique that I like to call enamel preservation and reinforcement. So again, your external outline is relatively small compared to what's going to happen after you remove the caries internally. You can see the periphery is clean, but then internally there's lots of caries, because you can see the red right there. As we know in the x-rays, the caries extends more apically. So now you see, after removing the infected dentin, because we knew it's infected because we stained red, but we still have this a wall of enamel that is still slightly bit supragingival. And maybe this is like 2.5 millimeter wall. Now, if I leave that and start restoring my tooth like that, life is a lot easier. But if I actually go and cut this away, as I learned in dental school, as we all learn in dental school, enamel without dental support, requires to be removed. And when you remove that, then you're like, now you're 2 millimeters below the gum and everything becomes more difficult. Now you have bleeding gums. You have to put a matrix subgingivally, which is so much more difficult, than wedge it and seal it. Why can't we just leave that? Well, that's what we do. We leave it, and you can see that the dentin portion is more apical than the enamel portion, I did a research study, an in vitro research study with the help of Dr. Warner Finger, who was the head of the dental materials department at University of Cologne. And together we did a research study to show that this technique is viable, works very, very well. And I've been doing it for years. And of course, by the way, this was not new. I mean, it goes back to the late 70s, 80s, where we learned the internal enamel reinforcement through bonding allows for that weakened tooth structure to become reinforced. And so there's lots of good studies on this, and we know that this is something that we can do. And maybe in the past we didn't know the benefits. Now we know. I mean, the benefit, the real reason why we would do something like this is to stay supragingival, and thus give our patient a healthier restoration. Every time your margin is above the gum, is going to be healthier. Is going to be easier to finish. Is going to be easier for your laboratory to see the margins. It's going to be easier for you to see the margin and trim it and finish it. Every time you go below the gum, everything's more difficult, So preparation like that is faster and healthier. Of course, that extends to a class 3. Instead of making this huge hole where we remove all the unsupported enamel, we make a small, external outline, and internally we expand. And again, we understand the benefit of adhesive dentistry. We trust adhesion, as I do. So of course, we're not going to try to make it so small that we don't have visibility. You need to be able to see what you're doing. So if it gets bigger, it gets bigger, but then internally it's always going to be bigger. And a preparation like that allows us to stay supragingival, and even a millimeter above the gum still is healthier than a millimeter below the gum. This is unhealthy. This is harder to do. Again, I keep repeating the same thing, but I don't want us to forget the benefit of this technique, enamel preservation and reinforcement. Do we have to bevel, spend the time beveling? I remember in dental school, we would teach our dental students they have to do a 1 millimeter perfect bevel, because, when you cut the bevel 45 degrees, you expose the enamel rods and da-da-da. Well, I mean, I just show you right there just a few of the research studies that pretty much clearly show that is not clinically is not critical. It's not that important, So why waste effort doing such a thing? I mean, I bevel when I'm trying to blend, a class 4, a class 3, where there's actually tooth exposure, and I want to blend the restoration with the tooth. So for aesthetic reasons, I bevel, not for adhesive reasons. A few megapascals of enhanced adhesion because of exposing the enamel rods is clinically unimportant, so I don't waste my time. So once we've done our preparation, then we're all happy. Now we're, if we do it like this, you're going to find that you're going to prep a lot faster. Then, of course, you put your matrix band, whichever you prefer, your wedge. And then the next important question, and remember, we're talking about doing restorative dentistry fast and efficiently, 15-minute filling. Does that mean that we have not using a rubber dam is a problem? I mean, this is another one of those things where people in Dental Town hate me because I have clearly, published the rubber dam isolation. There's no research proving the rubber dam isolation is any better than any other form of isolation. But we still hear from a lot of people, right here, there's just a post that kind of was a little funny to me because this colleague is saying, well, do you want good enough or the best? In other words, just like in Dental Town, they want to shame us because if we don't use, rubber dam. We know based on CR research, we know, surveys, we know that 95% of dentists don't use rubber dam, but they feel guilty about it. Don't feel guilty about it. The research is clear. Isolation is indispensable, but how you achieve the isolation doesn't make a difference. Clinically, there's no research proving that rubber dam isolation is any better than any other type of isolation. So, and especially when you're above the gum, then isolation is a lot easier, my friends. So, if you like rubber dams, I keep using them, but don't let people shame you. I know this is a biomimetic instructor, and biomimetics, they like to say that if you don't use a rubber dam, you're doing bad dentistry. Ignore that. That's an academic approach. That's going back to dental school, and we're out of dental school. And it's not as, and I can tell you this with research in hand, there is no proof anywhere that the rubber dam isolation will give us better clinical research. I went on Dental Town. I asked all of these people that were trying to cut my head because I was saying that, and nobody was able to prove otherwise. There's not such a research, at least not that I've ever seen it, and anybody has ever shown it to me. And I looked anyway. Moving into another subject. I just don't like when people shame us because we don't use rubber dam. That makes no sense to me. Then how about polymerization shrinkage? So now we're ready to go. We finished our prep, which is pretty quick. We did our isolation, which is very quick. We started to say supragingival. Now we're going to start filling our restoration using some of these amazing materials. And of course, polymerization shrinkage is a big deal. In fact, it's the biggest deal, because the polymerization shrinkage leads to open margins. That's the reason all of those leaky composites, especially in the cervical area, all those leaky composites is where people keep saying, oh, composite is not as good as amalgam, or, and it all has to do with polymerization shrinkage and stress, my friends. And let's not forget that last one. It's not just the shrinkage, it's the stress, And of course, that polymerization shrinkage also causes the gap, and the gap is one of the reasons why we develop post-op sensitivity. Properly done adhesive dentistry, properly done direct composite should have no sensitivity the next day, my friends. My patients never, of course, this is always an exception, but post-op sensitivity is a non-issue when we manage polymerization shrinkage. And trust me, this is a big conversation. And I, on my book with Dr. Ray Bertolotti and others, we really dig deep into this subject because we know this is the enemy. Polymerization shrinkage is the enemy. So much the enemy that some people, again, biomimetic group, they have published, as you see right here, techniques that are really very much trying to avoid the consequences of polymerization shrinkage. Of course, these techniques are clinically impossible to do. You need to do 10 increments to do a class 2, or, very small wedge-shaped increments. Wait 3 minutes in between. Use different types of composites. Do cure and wait, and then put inserts. Wow, I'm tired just to even talk about it. So my good friend Dr. Gordon Christensen, he did a very interesting study using his army of scientists in Utah. He tried a number of different techniques to see what would cause the biggest decrease in the effect of polymerization shrinkage. And the way they measured that was by doing a class 2 composite and then, you know, leaving it on water for a while and then staining it and see what, you know, where you would have the most leakage. And what they found, interestingly enough, what they found to be the biggest, you know, difference was, what made the biggest difference, to be clear, was the you know, the bonding system that we use and, you know, using it properly. So you know, the literature, and this is again in my book, the literature is very clear. I mean, lots and lots of research that show no conclusive evidence that so many increments are necessary or desirable. So I'm not a big believer on this doing 20,000 increments, because I don't have the time to do that. I'm a busy clinician, and I don't want to do a class 2 in 45 minutes, an hour. I want to do it in less than 15 minutes. And I use every available technology and technique possible. And I tell you, the one that I really like, and this is why I like this material, because guess what? It also has low shrinkage, you know? And so why not? You know, why not benefit from the advances in technology? So it's up to you. You want to do 20 increments or you want to do less increments, you know? So using materials like that has some benefits. I am not a believer of filling the entire cavity with one increment. I am not. I want to listen to experience, and I, you know, experience tells us, and experience going very, very far back, you know, from when my good friend Dr. Ray Bertolotti first explained to the profession that the composite shrinks in the direction of the best bond, and the best bond is always going to be enamel. And if you just do an increment, one bulk increment, and then you cure, even a small amount of shrinkage could cause a separation in the weaker bond, which is the dentin. So I like to avoid that, you know. Another thing that can minimize the effect of polymerization shrinkage is proper curing. You know, you know, we know that when we cure, when we give the composite a little more time to mature, to minimize the effect of polymerization shrinkage, that has a lot of benefits. I mean, this is again a short webinar. Lots of these conversations that we're having, you know, that I'm spending 1 minute on, I could spend, you know, and on our hands-on courses, we spend a long time explaining and really being able to understand, because understanding these principles allows us to when we're doing this clinically, understand what we're doing. For example, in regards to this polymerization shrinkage, you know, there's two extreme camps: the CR camp and Gordon Christensen, who have clearly shown, you know, that they clinically, this ramp curing and very slow curing is clinically not very important, you know. Now you see an opposite camps, you know, where they talk about, you know, and it is really true. In vitro, you can see how when you cure the composite too fast, the composite pulls away from the walls, and that will cause, that's the stress that will cause, you know, post-op sensitivity and open margins. So somewhere in the middle, you know, somewhere in the middle is where we need to be to understand that there is benefits of curing a little bit slower. So what I like to do to be more practical, you know, is I like to do on my incremental cures, I like to cure halfway the composite, you know, so use half the time in each increment, and then at the very end do a very complete cure. And we'll talk about that in just a minute. So understanding that you are giving, by not fully curing the composite, you're allowing the slow polymerization, and that decreases the stress. So a long conversation. Then, of course, the bonding procedure. so we can't forget, you know, the how we bond is going to have a huge effect on the results, as Dr. Gordon Christensen shows. There's some great bonding systems out there. You know, there's a good amount, and there's a lot of pretty poor ones. Right here, I show you three. They are spectacular. They're, you know, that you can, you know, they're going to do a great job. I've been using Futurabond and I love it. I mean, I'm a big fan of Clearfield IC Protect from Carrara. Certainly, you know, Prelude is spectacular as well. You know, using good bond, but there's something, you know, pretty consistent here. You see that they're all self-etch bonding systems, total etch bonding systems. I don't love it. And of course, I know some people just, they believe the total etch is the gold standard. I don't agree with that. The CR's literature as far back as the early 2000s were telling us already that people that use total etch bonding systems have a huge increase in post-op sensitivity. And the reason why is because it's technique sensitive. Self-etch bonding systems are not as technique sensitive. If you're a tiny bit wet, if you're a tiny bit dry, it doesn't matter. You know, you know, so you can never over etch, which is a big deal as well. So self-etch bonding systems are really good, and you know, if you want to use a nice bonding system from Boco, if you're, you know, reps are giving you good deals, Futurabond. Universal is very good. You know, I enjoy that one. But there's, again, as I said, there's a few really good bonding systems out there. You know, what I do strongly encourage you to do is make sure that you etch the enamel. If you etch the enamel, the literature shows that you don't just increase your bond strength, you also increase your seal, your marginal seal. Lots of great researchers have proven that. So do it. You know, don't hesitate. You only need to etch the enamel for 10 seconds, even less. You know, be careful. Only etch the external enamel, the uncut enamel. Or that's that little cable margin. That's where, you know, trouble can happen. Cure that. I mean, etch that. This is a good idea. And then, of course, you know, use your bonding technique properly. You know, as you can see right there, I'm carefully etching the enamel without touching the dentin. Then after you apply your bond, whichever bonding system you want to use, you apply the primer, then you know, make sure you get rid of the solvent. It's very important that you know, and then if you're using a single bottle, then apply it 25 seconds, then air dry it. Then of course, then we go into the filling steps, you know, which are very important. Few things, as I mentioned with Gordon Christensen's research study, one thing that you always have to do is cure your bond. Never leave the bond uncured before you start doing your increments. You know, always avoid increments, as I mentioned before on, you know, on a previous slide. Don't mix dentin and enamel on increments because they're two different initial bond strengths, dramatically different. Segment it, segregate them, keep them apart. It's a smart idea to do incremental cures instead of doing a full cure on every increment. You know, do a partial cure. You know, leave it a tiny bit. So you know, you allow the material to once you hit it with the light, you know, you start a process. Remember, composite doesn't cure for 24 hours. You initiate the curing, and once you initiate the cure, they will continue. And then, of course, you know, you know, it's a smart idea to not rush in filling your cavity, so that way every time you cure every time you hit the tooth with a light, you know, allow, you know, about 2 minutes in between. So, and then you'd have to do a final cure. So when I use this new material, which is very clever and has a lot of advantages, you know, Admire Fusion Extra, then the steps for a smaller medium cavity would be pretty simple. Again, finish my preparation, place the bonding system in cure. I like to do this, you know, which is apply flowable on the cable margin and on the and on the dentin floor, you know, and the reason why, as I said, is because I want zero post-op sensitivity, and by doing that, I know that I'm not going to have any problems. So, you know, you can use Admire Fusion Flow for that, and I'll show you what I mean by that. And then you know, small to medium, you can the second increment will be just your final restorative material. You know, again, because it has low shrinkage and a nice depth to cure, you can just, you know, put a larger amount and you'll do fine, you know. And then of course you need to do your final cure. So let's real quick go through that, because I know time is flying. So after your full bond procedure, then usually what I would do is I would apply my flowable on the dentin, you know, and then cure, apply flowable on the enamel cable margin, and cure. If you want to be if you want to be a smarty, you could apply the dentin and the enamel at the same time, as long as you are able to not unite them, to make sure that they are separated. You know, if they're not touching each other, you know, then you could do both at the same time. That takes a little more, you know, skill, you know, practice, you know, really good magnification. You need to be looking at what you're doing. You know, again, because you don't want them to connect, because then if you connect them, when it cures, when you're curing the material, the composite would pull away from the dentin into the enamel, which is stronger adhesion. So, and then after we do that increment, which doesn't take very long, then we can apply our final increment. Usually, you know, I mean, of course, the manufacturer of Meyer Boco says 4 millimeters depth of cure. I would not go to 4 millimeters. I personally prefer to do less. Not you can do more than 2. You know, I would say, you know, I would safely do 3. So we're talking about, you know, on most fillings, you can just do the flowable increment and then the final increment in most of the cases. You know, if it's a huge one, then I might put another increment, you know. So this technique, I tell you, you're not going to have any post-op sensitivity at all. Before curing, I strongly suggest that you develop the morphology. You know, developing morphology is very helpful, because what you do, especially when you use a nice instrument like you know, like an acorn. You know, I developed this composite instruments many years ago, which are really nice, and it has a nice deep, you know, deep acorn that creates a deep occlusal grooves. And the purpose of that, having these little grooves, is when you cure the composite, you know, even the 1.5 or 1.25, you know, polymerization shrinkage will not have the effect of breaking the sides, creating separation here, or even bringing the cusps together. So the way by creating the morphology before curing, you're also enhancing or decreasing the effects of polymerization shrinkage. So that's what I think is the clever approach. You know, instead of putting 10 increments, you know, use good materials that have low shrinkage, and then use them correctly. Understand these little things, you know, how you develop the morphology, how you know, you don't connect dentinate. Then you do those little things, and all of a sudden you achieve the same results as the people that are doing 20 increments to do a filling, you know. Again, as I mentioned to you, you know, post-op sensitivity is a non-existing things, and with this nice material, seeing white lines is never an issue. So And then of course, finishing is, when you use a number 12 blade, you can trim the flash in seconds. Use the number 12 blade. The only thing that, the only reason what a lot of people are afraid of using the number 12 blade is because of course, they're afraid of cutting themselves or cutting the patient. Use a two-handed technique. We teach in our hands-on workshops a technique to use two hands. Hold the instrument with two hands, and when you do that, you achieve maximum control. When you use when you grab your instrument, your number 12 blade with two hands, you're gonna find that it barely moves. You can apply as much force as you need, and you're gonna be able to trim that excess in seconds. Again, our goal is to do this class, 2s and class 3s and less than 15 minutes. And you can do it, and you can do an amazing restoration. You're going to be super proud of. It's going to have zero complications. And then at the very end, after you finish, trimming the excess, I use a 12-bladed carbide to remove the excess, whatever excess is left. If I develop the morphology before curing, the trimming is very, very minimum. And then before checking the bite, I will use an oxygen inhibitor. And oxygen inhibitor increase the cure, on your composite, but it also, if we are concerned about providing our patients the most biocompatible restoration, it also, it also locks in all the monomers by and there's a research on that, and it increases chances of margin staining because you cure everything all the way to the surface. It's a nice little thing to do, and I encourage you. I use KY jelly instead of the super expensive oxygen inhibitors. And then don't forget to adjust the bite correctly. I mean, the bite is a big deal, my friends. No red outside of blue. I like to, adjusting the bite correctly is really, really important. So make sure that you ask the patient to tap their teeth together, equal contacts throughout using the blue paper. Then you put the red paper and you ask the patient to grind left and right. Any red outside of blue, it's a lot of interference that will lead to post-op sensitivity. They will lead to fractures on your restoration. So only red on top of blue stays. Even a little bit of red outside of blue has to go. We have very, really good courses on occlusion also here at the LA Institute. And after you do the bite adjustment, then you just do final polish. I like to use the Jiffy brush from Ultradent. You want to have very nice rounded cable surfaces for more durability. And I tell you, you can have beautiful restorations in very, very little time with, knowing that you're going to have a lot of success. So it's been a pleasure. I tell you, an hour is such a little amount of time, as I mentioned before, we have a course on direct composite at the Los Angeles Institute here in Studio City. And people that take this course, they tell me that they actually can do composites in 15 minutes and successfully without sensitivity, without any problems. Understand adhesion really, really well. This course even includes a full mouth rehabilitation with direct composite. How do you like that? Direct composite is so underused in dentistry. So I know that now it's time to interact with you, my friends. I know there's a few questions out there, and I'm happy to tackle a few of them. So there's a question in regards to how do we know if the inflammation around the crown is caused by biocompatibility or the violation of biological width. I mean, for the crown to violate the biological width has to be very deep. We know that the biological width is 3 millimeters from the bone. Uh, Most of the times crowns are not quite that deep. But the moment that we place a margin below the gum, and I show you the research, and the slides show the research, and of course, if you go to my book, you can see a lot more of that research. The moment you put a margin below the gum, even a little bit, even a millimeter below the gum, that becomes a food trap, because no human makes a perfect margin. It immediately becomes a food trap, a bacterial home, home for bacteria, a place where tartar can get stuck, and all the negative things. So when you see subgingival margins, you're going to see inflammation, and that's what the literature says. Now, when you combine that and putting materials that are not biocompatible, then we are causing trouble, because the poor patient is always going to have their gum touching that, and inflammation is not unusual. Um, the question is, when removing the infected dentin, if it extends buccally and lingually, should we remove the unsupported enamel or leave it? As I mentioned before, fortunately, the bonded composite to enamel or dentin will actually reinforce the tooth. So we can leave certain amount of unsupported tooth structure, and once we bond composite to it, it will regain its strength. So now, when do we leave that unsupported structure? What's the benefit of that? Well, forever we have been leaving dentin in the fascia. When we do a class 3, we've been leaving dentin in the facial, enamel and dentin in the facial part of the tooth. We access the cavity through the lingual with the intention of leaving a little bit of life or a little bit of tooth in the facial for aesthetic reasons, right? So there's a good reason to leave unsupported enamel and on the facial of a class 3. There's a benefit to that, But if you don't have a good reason to leave unsupported dentin or enamel, then don't leave it, But if the benefit of leaving unsupported enamel is to stay supragingival, then absolutely. So leaving unsupported dentin on enamel should be done for a good reason. We shouldn't. It makes no sense to just leave it for no reason. So we need to be judicious about that, and that could continue talking about that, but I want to tackle other questions. So the next one is, by leaving the undermined enamel, is that also giving you a preparation retention form in any way? Okay. Probably it does, but I can tell you this for 100% fact. When you trust adhesion, you do, it doesn't matter. I don't care at all about having resistant and retention form. In fact, my good friend, Dr. Ray Bertolotti, feels that any type of, mechanical retention, mechanical features on a tooth is actually counterproductive. So if there is a little bit of, of resistance form there, well, or retention form, it's not too much of my concern. I have no desire or intention to put that in there. With uneven internal preparations, how do you avoid potential voids with composite placement? Oh, that's a very good question. Of course, flowable, my friends, flowable. That's the beauty of flowable. And the literature shows that when you use flowables, you have the ability to wet the cable margin better, to wet the floors better. So flowable. And that's why I suggest flowable first, and then use this wonderful material that you can do a bigger increments, a bulk fill, but don't over bulk, because that worries me a little bit. Would the snow plow technique reduce the C factor? Very good question about the C factor. Of course, we understand the C factor is the ratio between the bonded and the not bonded walls. the purpose, the intention. I mean, of course, we talked, you know, a good amount. Of course, with the limited time that we have, we talked about the use, the ways to minimize the effect of polymerization and shrinkage, and of course, you know, we do that in order to counteract the C factors and to counteract the negative consequences of polymerization and shrinkage. So we talked about how to take care of that. You know, of course, I wish I had a lot more time, but unfortunately, we don't have a lot more time. You know, so we're pretty much at the end. So maybe I'll take one more question. How many seconds do you do final cure? Does the size of the cavity dictate how long? And the answer is generally no. Generally, I don't. You know, I do a full cure facial, a full cure occlusal, and a full cure lingual of the cavity. So by doing that, I try to reach all these different surfaces under the oxygen inhibitor. So I apply that gel, the oxygen inhibiting gel, and then I cure, you know, always having the dental assistant blowing air. So while you're doing the final cure, you're not overheating the tooth, you know. So that said, my friends, I have to say is we way exceeded the hour that I had been given. And I you know, I'm honored that you took the time to spend it with us this evening. This is an exciting subject. You know, an hour doesn't give it justice. This material is very interesting. I encourage you to look into it. It has so many benefits, all in one material, right? That's why I found it exciting to talk about. So with that said, I wish you a great rest of your evening and good night. Thank you.
Here's how to take the CE exam at the end of the webinar. When the webinar is over, you may see some Zoom windows that are open. Close them all, including the one that says Join Meeting. Then return to the classroom page and click the Take Exam button. If you can't find the classroom page, go back to the website where you registered and make sure you are logged in. Look for one of these 4 links and click on it. Pending Exams, CE in Progress, My Account. You will then see one or more class titles. Click the title of this webinar and it will take you to the classroom page. Then click Take Exam. Thanks for your participation in Viva Learning webinars.